Let's review some key terms. The pressure plateau is the pressure needed to maintain lung inflation in the absence of airflow. The alveolar distending pressure is the pressure needed to overcome the resistance of the lung to inflation. The alveolar distending pressure is calculated as the plateau pressure minus PEEP. Static compliance reflects the elastic properties of the lung and chest wall. Compliance is inversely related to pressure change. Static compliance is measured when there is no airflow so that the airway resistance is not a factor. It is calculated by dividing the tidal volume by the alveolar distending pressure. A decrease in compliance means an increase in the work of breathing. Conditions such as ARDS, fibrosis, kyphoscoliosis, and/or atelectasis all have decreased compliance. Normal static compliance for a newborn is approximately 2.5 to 5 milliliters per centimeter of water pressure. Normal static compliance for a mechanically ventilated adult is between 40 and 60 milliliters per centimeter of water pressure. A patient with ARDS may have values as low as 15 milliliters per centimeter of water pressure, while a patient with COPD may have values as high as 140 milliliters per centimeter of water pressure. The clinician should use serial measurements to establish a trend. Unintended end expiratory pressure caused by incomplete exhalation is referred to as auto-PEEP. Some clinicians refer to auto-PEEP as intrinsic PEEP, inadvertent PEEP, or occult PEEP. Auto-PEEP is present when the pressure at the end of exhalation does not return to the baseline pressure, 0 centimeters of water pressure, or the set PEEP level. When auto-PEEP is present, the distal pressure in the patient's lungs can be as high as 15 centimeters of water pressure, while the ventilator's proximal airway pressure reading indicates 0 centimeters of water pressure. Auto-PEEP is calculated by subtracting the exhalation pressure at the end of a normal exhalation from the exhalation pressure at the end of an expiratory hold maneuver. Auto-PEEP may be associated with rapid respiratory rates, 1-to-1 or inverse IE ratios, pressure support ventilation, insufficient inspiratory flow rates, air trapping, and/or airway obstruction. Rewind and review the sections covering breath types, modes of ventilation, and key terms if you need to, before we take a look at the operation of the LTV and its controls in the next section.